Well, a very, very happy good afternoon to everybody. Hello, CNY Nation. I'm Dr. Randy Fink, live from CNY Fertility in Colorado, where I am the clinical director of IVF services and also the medical director of CNY Fertility in Miami. It's very good to see everybody. Glad you're all here. It's actually unbelievable. According to my watch, it's 80 degrees outside here in Colorado Springs. So go do the math on that. I guess it's not winter time anymore, but we're happy to have everybody here. Just trying to do a little last minute homework to bring out some make things a little easier for us to see. I guess that's not going to work. Gosh, how are you doing this afternoon? It's straight up, well, actually now at 4:02 p.m. Mountain Time, which means 6 p.m. on the East Coast. 4 p.m. Mountain Time. What do we say? Gosh, that means 5 p.m. in the Central Time and 3 p.m. Over on the West Coast. Good to see everybody here. We've had a good week. We've had a lot of folks getting pregnant here. Gosh, Music Blue, hello. By the way, you're amazing. You know what? It's feedback like that makes me keep coming back. Thank you for saying such very nice things. And gosh, E. Romero, we did your endoscopy this morning. Hello again. It's nice to see you. Here's a good question. Caroline says, any suggestions for painful PIO shots? Well, I will tell you, the PIO, the progesterone in oil, is it's like what I always say about, using a speculum in gynecology. It is our most popular medical instrument. The PIO shot is, of course, our most popular injection. It's pretty uncomfortable. It is. It's a thick liquid. It goes into the butt, which is never a lot of fun anyway. But actually, as long as we're talking about butts, I might just kind of show you a couple little tricks here. But before we get to that, I'll say, what can we do to kind of make that easier? And I'm sure that some folks here who are going to be joining us on the show this afternoon have some tricks. If you have a trick on what makes your PIO shots less painful, by all means, please share them. Some people say making sure their room temperature is helpful. Folks ask, do I need to do that PIO shot? Is it really necessary? Can I do some vaginal progesterone as well? We do typically add vaginal progesterone, but to be honest with you, the data is that for an embryo transfer, progesterone in oil significantly improves the outcomes compared to using vaginal progesterone alone. So we very strongly recommend that you do use the PIO, even though, frankly, it's pretty unpleasant. The other thing that I think is important is to know for sure that you're giving it to yourself in the right spot. And so here's where it comes time to let's show Randy's butt. Oh, Beverly says, yes, apply heat to the area 15 minutes prior, then massage the area where you injected. The other thing, okay, so forgive me. All right, I'm going to leave my pants on here, but I will show you. A lot of times when folks go to do their injections, they're actually giving them into the wrong place. The intramuscular injection is designed to be into the muscle, not into the fat. And if you go into the fat, and obviously there is a layer of fat on everybody's booty, if you go into the fat, then it is going to hurt much more and can result in something that's called fat necrosis, which is where the fat cells will start to dissolve. So, important thing to note. So here's the butt, and of course I'm wearing black, so you can't tell today, but you see kind of where the fig's mark is over there. Here's my hip bone. The place where we want to go is really just kind of right here. It's not over here in the butt. It's not down here in the butt. In fact, we have a big nerve that runs down here, and that's our sciatic nerve. And we certainly don't want to get that needle exposed to the sciatic nerve. But it's over on the side there in the muscle. If here's the hip bone, it's going to be really just below it there. So that's one of the more common things that I see folks giving themselves shots in the wrong place. So Beverly says apply some heat. I think that works too. Thanks for that. Some folks will get some Emla cream or some type of numbing medication to put on the skin. And while that does help with the needle going into the skin, it's not going to change the sensation of it going into the muscle. And sometimes also it would be being able to also ice it afterwards, although heat and massage sounds like a good answer there as well. Kaya Lene, it looks like, had an endometrial biopsy and it came back inactive surface endometrium and preparing for my transfer. Should I be worried about implantation? So when we do an endometrial biopsy, we're placing a little straw inside the uterine cavity in order to suck a little piece of tissue out so that somebody can look at it under the microscope and tell us that it's normal. What are we looking for? Well, on the one hand, so there's a different story if you are, for example, having postmenopausal bleeding. We're looking for different things. That's a different sort of scenario. But one, we know the brain is talking. And if the brain is talking, is the uterus listening? And that's the first thing that endometrial biopsy will show us. Inactive surface endometrium tells me that it's probably not really well stimulated at that point by the medications. And so it's not uncommon to find that just sort of quiescent endometrium that's sitting there without being told what it's supposed to be doing. But the other thing that we really want to know about is do you have endometritis? So if you have an endometrial biopsy, I think it's very important that you know this is something that we're looking for and that you make it a point to follow up on your results to ask the question. There's a type of immune cell that's called a plasma cell. Plasma cells in the lining of the uterus are diagnostic of what we call chronic endometritis. Endometrium is the lining of the uterus. Endometritis is an infection or an inflammation of that uterine lining. And so the presence of plasma cells tells us that you need an antibiotic. That's probably a more important feature, Kaya, there. So as long as your lining is growing, as long as it is at least 7 millimeters at the time of embryo transfer, or really at the time of progesterone start, I would not worry about that biopsy result. And I sure hope that helps without being overly confusing. Is the leg progesterone shot okay? That's a good question too. Do you have to give it in the butt? Can you give it in your leg? Yes, you can. In my opinion, the progesterone shot into the leg is just more painful. This muscle here into the quads or into what's called the vastus lateralis or the vastus medialis, either way, it hurts. And so to me, it's easier for me to think about, and men do this with testosterone, so it's easier for me to think about sticking myself here than it is to be looking at my leg and what appears to be stabbing myself with a needle. Now, there are auto injectors, and in fact, someone was kind enough in last week's live to talk about where that comes from, and it's called Union Medico. Union, U-N-I-O-N, Union Medico, which I believe somebody told me is a Danish company. And if you tell them it's for the PIO shot, they give you everything that you need. In fact, we have a very, very, very kind soul who I want to give a shout out to. I don't know if she's watching today, and I didn't ask her permission to use her name, but so I guess I can't really give her a shout out, can I? But she is taking a little break from doing treatment and sent us 2 big boxes of supplies and things that she wasn't going to use in hopes that someone else would need them and that, she wanted to be able to donate them, which is just a really very beautiful thing to do. And it's there was an auto injector with it. And I think that auto injector has got to make giving yourself a PIO shot much easier. Some people will go to, they'll have a nurse friend, or will go to the local fire station, a paramedic or fireman do it. Lots of different solutions for getting that painful shot in there. And Lori here is telling me that you just have to tell them the size of the needle and the syringe, and they come pretty quickly as well. So thanks for that information. Here's a little message from Ariel. Hi, Ariel, on the Facebook side. By the way, we've got Facebook and LinkedIn over here, and a couple of different Instagrams right here. So again, glad to have everybody with us in Colorado Springs this afternoon. Ariel says she got 9 embryos. Well, that's fantastic. Congratulations, Ariel. I have about 5 or 6. I have about 5 or 6 CC embryos, and the other 3 or 4 like BC or BA. Is implanting the CC worth it? This will be my 3rd round. Okay, so what Ariel is asking about is embryo grading, and so she has both some BA, BC, and CC embryos. In terms of embryo grading, I will tell you, Ariel, I would not let that be a criteria for deciding whether something is going to work or not, because embryo grading is a beauty contest and nothing else. And if you know anything from ever watching, for example, the Miss America pageant, some of them, this one plays the violin, that one plays the piano, this one sings. Are any one of those people better than the other one? This one looks good in a bathing suit. That one looks good in evening wear. Does that matter? Are any of them not beautiful? No, they're all beautiful in their own ways, but each has their own unique characteristics. Embryo grading was really designed to try to give us some ability to look at an embryo and determine, is it going to be a normal embryo or not, based upon some criteria of the embryologist looking under the microscope. And the answer to that is no, you can't tell, because when we do PGT testing on embryos, when the embryos are biopsied, we may have the very ugly ones, or the ones that are poorly graded. And I hate to call them ugly because, it gives them a complex, and life's hard enough as it is without starting them off as embryos with complexes. But we can do PGT testing and see that the chromosomally normal embryo may be the lowest or the poorest graded embryo of the bunch. And if that's the case, then what's the use of embryo grading? And I would ask really the same kind of question. Well, they got to have some criteria by which to say, okay, here's number 1, here's number 2, here's number 3. But at the end of the day, that grading really does not correlate so much with outcomes. So is it worth transferring embryos that are not highly graded? The answer is, Ariel, yes, all day long. Don't think for a minute that you should get rid of embryos. It doesn't matter what they're graded. Even poorly graded embryos can give you absolutely beautiful, perfect babies. So congratulations on that outcome there. Maria is telling us that she has a hydrosalpinx that has been blocked with clips. Should I be worried to continue transfer? So hydrosalpinx, we've talked about this before, and I have my friendly neighborhood uterus here. Hello. Hi. So a hydrosalpinx is, and forgive me if you've seen this before, but I got to use this. Somebody gave this to me, and it's brought me so many years of joy that she just has to join me at every opportunity possible. A hydrosalpinx is when there is fluid that's here in the fallopian tube. And when there's fluid in this tube and we go to place an embryo inside the uterus, the fluid can wash its way back inside and is toxic to an embryo. So in the situation of having a hydrosalpinx, salpinx means tube and hydro means fluid. When there's fluid in the tube, we want to do one of two things before you put an embryo in. One, we either want to remove the tube outright because it's a damaged tube, it's full of toxin, we want to get it out of the way so it's not going to affect the embryo. Or the other way to do that is just to basically do a tubal ligation. And that is to put a little clip or a blockage on the tube here. And if it's on that side, on the tube here, so that the fluid does not have a way of getting back into the endometrial cavity and affecting the embryo. One is just as effective as the other. Both typically require a laparoscopic surgery. So the putting a clip on the tube takes all of about, probably under a minute once you're inside with the laparoscope. It's very fast and very easy to do, as opposed to removing the tube, which takes a little bit longer. But the answer there, Maria, is yes. Oh, wait. Yes, it is okay to do your transfer since that tube has been ligated and that the hydrosalpinx has been blocked. Let's see what else we have here. So nice to have everybody in the building. You might have just heard that our fire alarm was going off here in the Colorado building. And so if the fire department comes in here, we'll keep talking until they tell me I have to start, then I have to stop. Tayrad 32 says, I'm getting ready to do a retrieval in May while keeping my IUD in. Fabulous. And then I'll do a frozen transfer afterwards. How long after the IUD removal can we do a transfer? So in her situation, the IUD was placed to treat endometrial hyperplasia. And let's talk about what that means. The endometrium is the lining of the uterus. Hyper means too much. Plasia means growth. Endometrial hyperplasia is a situation where, generally hormonally mediated, that the lining of the uterus is getting too much signal that results in an overgrowth of the uterine lining. This often presents with very heavy menstrual bleeding. It's sometimes more common in women who are a little heavier because much of that hormone is processed in the adipose cells or the fat cells in our body. Endometrial hyperplasia, and there's 4 different types of endometrial hyperplasia, can be precancerous. And the reason that we want to find it and that we want to treat it is because endometrial cancer is a preventable disease. It's nothing anybody needs to have. And it's really just an out of balance situation between estrogen and progesterone. So if you've got more estrogen than you do progesterone and they're not balanced out, what do you want to do? You want to add some progesterone to balance things. The hormonal IUD, which there are 3 or 4 different brands of them now, is made with a hormone that's called levonorgestrel. The levonorgestrel IUD is a medicated IUD. IUD is an intrauterine device that is designed as a method of contraception. So when we place an IUD in the uterine cavity, it thins out the lining of the uterus so that sperm can't swim around on the inside. It's like taking water out of the pool. If you take water out of the pool, there ain't no swimming in the pool, and the sperm kind of think the same thing. And so that's the way it functions as a contraceptive. The side effect from that IUD is that there is about a 90% reduction in menstrual blood flow. So for women with that IUD, most of them will end up not having periods at all, or sometimes just a day or 2 of spotting or a little short period. Some people will get a little bit of spotting that lasts for a longer time period, and that can be annoying. Some people in the first few months may have some bleeding every single day, and that is truly annoying. But ultimately, placing that levonorgestrel IUD in order to balance out the estrogen situation and treat the lining of the uterus directly with progesterone is a very effective means of reversing that process of endometrial hyperplasia. So that's why you have it. I have had folks tell me before that they have been told that they need to remove their IUD in order to do an egg retrieval. And the answer to that is no, that is not correct. Don't let anybody tell you that. It is wrong. Your IUD can stay there, T-Rat, for as long as you want, and you can retrieve as many eggs or do as many cycles of egg retrieving as you can tolerate with that IUD in place. Then you take it out. And then what happens? Well, then the lining starts to grow back. How long do you need a lining to grow back? Well, to be honest with you, probably your first cycle after removing the IUD, you should be able to proceed with an embryo transfer. If you wanted to be extra cautious and judicious, you could take the IUD out, leave it out for a month, and kind of just do a mock cycle. Just take a look with the ultrasound at mid-cycle to make sure that the lining is in fact getting thick enough and that it's doing what it's supposed to be. And that's a kind of a conservative way of doing it. But great idea to have the IUD. Don't take it out until you need to have it out. And then once it's out, pretty quickly, your body will return to normal. All right, let's see what else we have going on here. Buddha B would like to know about follicle size at the time of trigger. There's a good question, Buddha B, and I honestly just like saying your Instagram name. So at CNY, well, so there's different answers to that. When we're doing an IUI or an insemination, we usually, or even just timed intercourse at home, we usually look for a follicle that's about 18 millimeters to be able to say that it's mature. When that follicle size is 18 millimeters, then we'll say, okay, time for your trigger. Go home and do what you have to do, because 36 or so hours after you get that trigger shot, your ovary is going to release its egg. Now, in nature, that follicle may not release its egg until it might not be 24, 25, sometimes even 26 millimeters. So it doesn't mean that at 18 in nature that you're going to release your egg on its own. The point is that it's mature at that point. So once it's mature, it's ready to go, and there's no reason to wait for it, especially if we're trying to do something like getting sperm to where that egg needs to be at the right time, right? So that's what we do with timed intercourse or with an IUI. As for IVF, we usually look at 16 to 17. We want probably half of your follicles to be of a mature size before we say you're ready to trigger. Now, sometimes you'll have follicles that are growing out of sync, that you may have a couple of follicles that are 20, a couple that are 16, and 10 of them that are 14. Well, if that were the situation, I might say, you know what, Buddha B, you've got 12 follicles here that are 14 millimeters, so why don't we let those grow a little bit? We'll sacrifice the 4 larger ones because they may just disappear. We'll let them go in order to be able to get the 14s that we have, a whole bunch of 14s that may be a little smaller. So in that situation, we give it a chance and let them catch up. So that's kind of the way that works. And Emily 3 wanted to know that question too. So thank you guys for asking. Thanks for listening. I'm sure glad you're here. It looks like Haley is asking, is there a way to improve uterine lining naturally for a chance at a fresh transfer? I started another cycle 3 days into stems and should have a retrieval sometime next week. Okay, so First of all, let's talk about fresh versus frozen transfer, because this is something that comes up all the time. And then actually, I want to go back. Haley asked the same question, or is it Hallie? I apologize if I'm mispronouncing there. Also asked about day 3 versus day 5. So let's see if we can cover all that here at once, just so that we're all on the same page. So we generally tell you that we want you to have an embryo, right? So a day 5 or a blastocyst, which is typically day 5, day 6, or day 7, is more likely to get you a baby. Why is that? Well, that's because that blastocyst has changed over from being a little cleaving bunch of cells that are just trying to divide, and has become a little factory. It's become a little metabolic factory. It's growing. It's doing what it's supposed to do, and it has lasted to the point where it is now what we know of as a blastocyst. So some embryos will not continue to grow on their own, and if that's the situation, well, then we may end up not having any blasts at all. So generally, we tell you that if you've got a bunch of embryos, and our typical protocol is that if you have 5 or more embryos, we recommend that you grow them out to the blastocyst stage. Why? Because it may ultimately mean fewer transfers for you to have to do, because a blast has a greater probability of being able to get you a pregnancy. But is there a problem with the day 3 embryo? No, there's no problem with the day 3 embryo. Day 3 embryo is fine, because if we're limited in the number of embryos, we would much rather see an embryo going inside of you than an embryo potentially not growing in the laboratory. Because you may have that magic sauce that the laboratory doesn't have. Best case scenario, the lab is the lab. Your uterus is your uterus. What does that embryo want? It wants you. So it may grow inside of you, whereas it might not have grown inside the laboratory. So if we're limited in the number of embryos, we will tell you either freeze or transfer, do what you're going to do with a day 3 embryo, because an embryo inside of you is better than an embryo potentially in the trash all day long. All right, so that's day 3 versus day 5. Fresh versus frozen. A fresh transfer is, of course, when we place an embryo back inside of you in the very same cycle that you have had your retrieval. So we're retrieving the eggs. They're going to the lab. We're making embryos, and then we're transferring an embryo back into that same cycle. Fresh transfers do work. A fresh transfer is included in the price of the IVF here at CNY. You can imagine that your body is in egg-making mode. If you know from doing your retrieval or from doing your monitoring, when you see all those follicles in the ovaries, your body's making eggs, right? That's what it's trying to do. It's trying to make eggs. And making eggs sometimes is not consistent with being pregnant, because egg making mode may not be the same thing as being pregnant mode. Your body is trying to make eggs. And so sometimes there's a hormonal situation where we can look at some blood tests that will tell us, this is a bad idea. It's not going to work. And so we may tell you, don't do a fresh transfer. We don't want you to waste an embryo. Or there can be times, all the numbers look good, so maybe you want to do a fresh transfer. But even in the best case scenario where the numbers all look fine, the data shows us that there's still a slightly higher chance for success with a frozen embryo transfer. And that's because the body is out of egg-making mode and is ready to be put in getting pregnant mode. So doesn't that just make sense? If that's the situation, let your body recover and go back and do a frozen transfer instead of a fresh transfer. Especially if you're over 40, the success rates with a frozen transfer are significantly higher than those with a fresh transfer. So I encourage everybody in that situation to think about doing a frozen. So is there a way to improve the uterine lining naturally? Well, when you're getting your stems Hallie or Haley, Miss Kavanaugh. We'll go with that. Miss Kavanaugh, when you're doing your stims, your ovaries are producing estrogen, and that's going to make that uterine lining as thick as it can be. So naturally speaking, you really don't have to do anything else to treat your lining if you're planning to do a fresh transfer. The biggest concern is not being overstimulated, and we would typically look at that by one of two different numbers. First is the estrogen level. If the estradiol level is above about a 3,000, then it means that the likelihood of a fresh transfer working becomes significantly less. Not only that, if we do an embryo transfer and your estradiol is 3,000, you also have a tendency to, if it does work, you have a tendency to become very, very ill with that. And that's obviously something that we would really prefer to avoid. So, and the other number is, now I will tell you there's a caveat with that estradiol number, and that's because so many of our patients use a medication called letrozole with their stimulations. And if you're using letrozole with your stim, letrozole will artificially lower your estradiol level. So the estradiol level will not be accurate if you used letrozole, the pill form, during to help with egg recruitment. The other number we would look at is progesterone. The progesterone level, if it's above about a 1.5, then in all probability, the transfer is not going to work. Why is that? The progesterone kind of controls the window of implantation. It's a good window, it's a narrow window. As that number starts to approach about a 1.5, the window becomes narrow and narrower until it's above that 1.5 number, and the window's really closed. And it means that the lining of the uterus is just not going to be hospitable to the pregnancy. So now I will tell you at CNY, we'll do what you ask most of the time, unless we think it's actually going to hurt you. So if you want to destroy an embryo that way or use an embryo that way, even though we're telling you we think it's not going to work and the probability is that you're wasting it, they're your embryos. So in most cases, we will let you do it unless the number, your estradiol is very high, in which case then it starts to become risky to you. And our job is to first, even though we want to acknowledge your autonomy to be able to make those decisions. The job is first to do no harm, and then we would say, no, really, we just really don't want you to do it. Let's see here. I would like to get. It looks like emptiness. Oh, I like that name. Emptiness dancing. Wow, I find that that's really a good name. Emptiness Dancing said, well, actually, Emptiness Dancing is also very smart because they say, you are so great. Well, since you said so, yeah, thank you very much. That is very flattering. I appreciate that. I would like to get a saline sonogram, the same cycle as doing a fresh transfer. Not advised. Why not? Because when we've gone to the trouble to make that beautiful, perfect little embryo, we want that lining to be such a beautiful, perfect little place for it to go back in. I don't want anything messing with your lining. I don't want fluid touching it. I don't want the catheter poking into it. I don't want pieces of debris flying around on the inside of it, which is what happens every time something goes into the uterine cavity. And anything going in there can have a negative effect on the embryo's ability to implant. So I would strongly recommend that you do not do that. To me, that's not something that makes a lot of sense. So I see Grace Tongue joined us. Hello, I just saw you today. Nice to see you there. Let's see. Amber Vince is with us from Kentucky, who is already making fun of me. That's all right. That was probably much earlier in the broadcast, and I'm just later on. I missed that before. Oh, hello, Inez in Miami. It's nice to see you. Let's go over here to this Facebook side, or rather to this Instagram side. Misa K5 said, I had chronic endometritis and it was treated with antibiotics. Does the area need to be tested again if it's only been 3 months? So with the chronic endometritis, which we talked about as evidenced by the plasma cells on the biopsy, we typically treat that with 2 weeks of doxycycline, which is a simple antibiotic that you just take usually twice a day for 14 days. And that should take care of that chronic inflammation. I usually like to think about doing a biopsy again after about 6 months. So at the 3-month mark, I think you should be adequately treated, and no reason to do a rebiopsy. And good luck with that transfer there. Facing Destiny 1922. Facing Destiny says, my first fresh transfer failed, which is really frustrating. And 44 with a low AMH. Should I do another egg retrieval or add donor egg? This is a quandary, but it opens up a bunch of different options for you, Destiny. With the low AMH, it means that we are going to be limited in the ovarian reserve. The other feature which means that, of course, we're born with all the eggs that we'll ever have. And after puberty, the numbers of those eggs starts to diminish to the point where after 35, it's about 10,000 eggs a month that we're losing. So we're going to lose eggs, but there's also the issue of egg quality, which is having stable DNA in order to be able to make embryos that are chromosomally normal. Well, so what should you do in that situation? You can certainly do your own retrieval. So before you did anything there, I would 100% recommend that you talk to us about the supplement list that you should be on, because we can absolutely have a positive effect on egg quality by addressing the biochemistry of how those eggs are recruited. And that's done with simple supplements. So we have created, and I say we, that here in our Colorado office, we have created, based on the book, It Starts with the Egg, a curated list of each of the supplements that is evidence-based and what the evidence is. We've validated that, found the right formats of these supplements and the right doses, and then looked for the best prices that we can find and put them on a list. So if you haven't gotten that and you would like it, I am happy to send that to you. Just Instagram me through Randy Fink MD on Instagram, and I am happy to send you a link to those protocols. So first thing, Destiny, is I would absolutely be on the supplements to try to improve egg quality. I think there is no harm with doing a retrieval yourself, and adding a donor egg backup. And what does that mean? Well, it means that we still go through a stem for you. So we still have the possibility of getting eggs and making what are called autologous embryos. So that's embryos that are made with your egg and with your partner's sperm. But you've also purchased a group of donor eggs. And typically the egg donors come from young women with very stable DNA who are usually proven to have been successful with having kids before. And in that scenario, we know that we're going to get you some embryos that have a good probability of being able to make you pregnant. So in that scenario, you kind of get the best of both worlds. The odds, or rather the chance of being able to do it yourself, especially if you can upgrade what's going in your mouth in terms of the supplements to affect that egg quality. And secondly, to be able to have the benefit of doing a donor egg backup. It ends up to be a little bit cheaper as well, because when they're doing the fertilization on your eggs, and the fertilization on the donor eggs, it's kind of all the same transaction in the laboratory. So it becomes a little easier than having to try to do those things separately. Good luck with that process, Destiny. And thanks so much for being with us today. It's about 20 minutes until the top of the hour. Fertility with Fink and Friends live in the CNY Nation from Colorado Springs. Glad to have everybody with us. We'll be here for about another 20 minutes. If you got some questions, throw them my way. I'm trying to get into to everything here, but I'm never successful with it all. So Myra would like to know, and it looks like from the Facebook side, why is your clinic so affordable? I want to consult, but I'm skeptical since all the other clinics run you $30,000 or more. It's a great question, and I always am fond of saying that one of the reasons that I really enjoy being here at CNY Fertility is because we are able to open up to everybody. You should not have to be uber wealthy to be able to experience IVF and to have a child if you're having difficulty. It does not need to cost $30,000 for IVF. When they do that, they are just selecting out people who can self-pay for that. And I find it really, frankly, unnecessary. How does CNY do it? Well, we have a different kind of volume principle. So we see a lot of patients. And because we see so many patients, we can do it at a more affordable price. So the average IVF clinic will see the average doctor probably 100 to 150 cycles in a year. At CNY Fertility, we may do 15 to 20,000 cycles in a year, which is really impressive. It exposes us to all manner of different possibilities and all kinds of different people and all kinds of different reasons that they're having a difficult time getting pregnant. And so we see a lot of things. I do probably on average about 150 egg retrievals, between 125 and 150 egg retrievals in a month. And that's about what most reproductive endocrinologists will do in a year. As far as our embryo transfers here, our nurse practitioner, Brandis, does a lot, really most of the embryo transfers while I'm doing the surgical procedures in the operating room. We do switch off there. But Brandis has done in excess of, over 1,500 transfers just in the last year alone. And do you realize that for most reproductive endocrinologists, that may be 10 years worth of transfers? So the kind of experience that we have here is really unmatched in the industry. But because we're able to keep the price so affordable, we're able to open the doors really for everyone. And because we can open the doors for everyone, we are able to keep the price so affordable. But great question, Myra, and we would love to be able to help you with the goal of achieving your family. Let's see. Looks like Rosanna says, how do you approach possible endometriosis when preparing for a frozen embryo transfer? Endometriosis is the situation where the uterine lining, instead of sloughing off and coming out, which we know it does when you have a period, instead it works its way up north. It kind of gets inside the pelvis and implants within the abdominal cavity. And what does it do? Well, it can, in many people, it causes a pain syndrome. And so it's one of the most common causes of severe dysmenorrhea, which means painful periods. It's a very common disease process. But in some people, it also is a silent disease, and that's what we call silent endometriosis. Endometriosis can affect egg quality, but we're asking about the embryo transfer here. With an FET, how does endometriosis stand in the way? And this becomes a concern, Rosanna, particularly when folks have had repeated embryo transfers and are not being successful. Part of the workup for us is to want to know, is endometriosis involved in this situation? Because the brain is talking to the uterus, right? We talked about that with the endometrial biopsy before. The brain is talking to the uterus. Endometriosis stands in the way of that communication. How does the brain talk to the uterus? Well, it uses hormones. That's the language. But endometriosis kind of interrupts the flow of electricity, if you will, and stops that communication or messes with that communication that ultimately can mean that the embryo doesn't know how to implant. So if your embryo transfers haven't been working, one of the things that we're going to start to look at is, could there be endometriosis involved? There are some doctors who feel very strongly that a laparoscopy is necessary and is a necessary part of your evaluation. And in fact, I've been told that in earlier days of fertility care, you would often be scheduled for a laparoscopic surgery before you ever even met the doctor. So nowadays, there are some other options. A laparoscopy is a surgery where we place under general anesthesia, so you're completely asleep and nothing hurts. We place a little camera into the belly button and be able to take a look around inside the pelvis. And that gives us the benefit of really seeing everything that's on the inside here. We can look at the liver, the gallbladder, the ovaries, the tubes, the bladder, the colon, the posterior cul-de-sac, which is the area underneath the uterus. We can look at the appendix, at the abdominal wall. We really can get a lot of information, and we can also treat situations then. So if there's endometriosis, we can treat it. And the recommendation now is that we remove it, which is called resecting it. In the olden days, we would really just kind of buzz it and burn it. But now the recommendation is actually to physically remove that portion of the abdominal wall lining. And why is that? Because the endometriosis that you see is considered to be just the tip of the iceberg, meaning to say that I can buzz or cauterize a little piece of endometriosis, but there's likely to be more of it underneath the surface. So the recommendation is that we remove it. So surgery is one option there, Rosanna, but the other option is that there's a non-invasive test that's called Receptiva. Receptiva is an endometrial biopsy that's done at a particular time during the cycle that looks for the presence of a particular protein that's called BCL6. And BCL6 is an inflammatory marker that is associated with a 93 to a 96% sensitivity. So it's a very, very accurate marker for endometriosis. So we place a little straw inside, we suck a little piece of tissue out, and if that test comes back positive, the data shows us that there may be a 12% or lower chance of being able to be successful with an embryo transfer unless we treat that endometriosis. And how do we treat it? There are different medications that we can use, but typically we suppress the endometriosis by using a medication for about 60 days. So 2 months is all it delays you. And during that 2 months, we're turning down the volume knob on the endometriosis. And by so doing, we can improve the outcomes of embryo transfer by 60% or more. So it makes a lot of sense to think about diagnosing endometriosis if indeed transfers have been a problem. We start thinking about that certainly after 2 euploid transfers, or certainly 2 to 3 untested blastocyst transfers. We really kind of want to start thinking about, is endometriosis possibly involved in this equation? Let's see what we have here. Looks like Megan Blanton. Hi, Megan. I had 2 more embryos added that I just found out about today. I had my egg retrieval 2 months ago. Why did I have some added later on? I was originally told I had 4, and now I have 6. Well, that's what we call serendipity, isn't it? That's probably not a bad thing to have to uncover. Congratulations. I guess you get probably 2 extra little birthdays there. So, one of the things that happens is that when embryology is looking at, let's say we retrieve eggs, and then they try to fertilize the eggs, we look at those eggs 24 hours later. So that's on day 1. And that's when we give you what we call our FERT report, the fertilization report. Some of the eggs will not have shown fertilization on that day one FERT call by the time we give it to you. By the time we give you the answer. And why is that? Well, because some of them fertilize a little late when the embryologists are looking under the microscope and looking for the signs of fertilization. Sometimes we just miss the window. So if there's any question at all, the embryos are kept and they're looked at again a couple of days later, typically on day 3, to see if they continued growing. Now, what's supposed to happen there is that the report should actually come to you, Megan, that tells you that, yes, there was a change in your original numbers that were reported from your day 1 FERT call. But sometimes, to be honest with you, they get so excited about the fact that now we have more eggs than we began with, that sometimes that communication just falls through the cracks. So I'm very sorry that happened to you, but at the same time, I'm also very happy that happened to you. I'm very glad you got an extra couple of chances at getting that family that you so much deserve. Let's see here. We'll take a look back on this Instagram side here. Oh, actually, Amber Vince is telling me going back to PIO, heat it up under your arm. Make sure you're doing it high enough. Lots of people do it too high. Okay, and use the massage gun after to help prevent knots. So yeah, it does go in the muscle, and what happens after it goes in the muscle is that it creates what's called induration. Induration is the hardness that you feel, and literally that's an inflammatory response, and we need that inflammatory response because that means your body is figuring out how to get to that progesterone to use it. Thanks, Amber. That's very, very helpful. Hi, Mayeli. Nice to see you. Thanks for being here. Let's see. Grace said, thanks for the smooth transfer today. I will thank you if you'll just get pregnant. Would you mind? I don't think that's too much to ask. By the way, when all you folks get pregnant, and you all will get pregnant, we're going to really work on that for you. We love to see pictures of your family. We love to see to get the Christmas cards with your family photos. We love to hear the stories about how much joy your families are bringing you. So please keep them coming. And certainly, I can speak to that, here in Colorado. We live for that. I live for that. That's the reason that I want to come to work every day, to see those happy faces and get those stories. But across CNY as a whole, if there's someone that you've interacted with, one of our nurses or one of our staff or somebody on the phones or anybody who has touched your life in some way, it means so much to us if you have the ability to reach back out and let us know kind of what happened with you, because a lot of times once folks get pregnant, we stop hearing from them, and gosh, it makes it all worthwhile to hear your success stories. And for those of you who are still waiting for those success stories, we are here and we are waiting with you. We are just as anxious and just as excited for your positives, and can't wait until we can make those phone calls. Allison's asking, can metformin help with insulin resistance and ovulation? Or I know that it can help, but how does it differentiate from letrozole? Okay, so letrozole is designed as an ovulation induction agent. Letrozole blocks your without going into too much detail, we all have testosterone in our body, men and women. Testosterone is converted into either the active form of testosterone, which is what gives us pimples, or it is made into estrogen. Well, in women, if we block that conversion into estrogen, the brain says, oh, we need more estrogen. Where does the estrogen come from? The estrogen comes from ovarian follicles. And those are the little cells, the granulosa cells that are surrounding your eggs. So we give you letrozole. It's going to block your estrogen. It's going to increase your pituitary's secretion of the hormone that's called FSH. FSH is the medicine that you know from IVF as Gonal-F, or follistim. We want you to make more FSH so that you make more follicles because your body's trying to give you more estrogen. Metformin does something different. In treating the insulin resistance, it can improve the odds of you ovulating because insulin resistance is one of the features that sort of stands in the way of our metabolism working the way it's supposed to. So many women who don't ovulate, for example, polycystic ovarian syndrome, will use metformin because it can help restore normal ovulation. But metformin also can improve egg quality. So we use it in folks who have a diminished ovarian reserve or have shown us egg quality issues, and can also decrease the risk of miscarriage. There's a supplement that can do that really as well, and that's called myo-inositol. Myo-inositol does kind of the same thing as metformin does, but it doesn't have the same kind of GI side effects that metformin does. It can make you bloated and gassy and diarrhea until your body gets used to it with the metformin. There was a question back here from Cheryl. What was the contact information to receive that supplement list? You can Instagram me directly, and that's Randy Fink MD. At Randy Fink MD, and I'm happy to send you that list. We're going to have to be winding it down. I think we got about maybe 4 more minutes or so here. Can you do IVF if you bleed between cycles, or is this something that has to be controlled? Well, that comes from Fit and Healthy 26. Nice to see you here today. Not 100% sure what you mean. Can you do, bleeding between cycles is often a hormonal situation, but it can sometimes also be a mechanical situation. You can have a chronic inflammation in the lining. You may have an endometrial polyp. And these are things that we always want to know and that we will diagnose as you go through the IVF process. But generally speaking, if you've done IVF as a retrieval and then you start bleeding before you're supposed to, we don't want to be doing an embryo transfer because that means that your lining isn't quite ready. So hopefully got the question there. Do I recommend the lipid infusions, or are they a waste? And that comes from Jasmine. Hi, Jasmine. I do recommend them if you can do it. A lot of folks have a hard time finding a facility to be able to do the infusions, but the lipids are like an IV version of the keto diet. It's very profoundly anti-inflammatory. And so if you can do it, you should. It is the treatment of choice for those who have something called elevated natural killer cells, which is an autoimmune response. And so, yes, even without testing for an intralipid is probably a good thing to do. So, Jasmine, I do recommend it. An HCG wash, Maddie Morris Photo is asking, what do I think about an HCG wash? Yeah, I do like the HCG wash too. The data shows us that placing a little of the pregnancy hormone inside the uterine cavity turns the volume knob up on the lining of the uterus that makes it more receptive to an embryo. So it's pretty quick, it's pretty easy to do. We do them in our office, usually the day before transfer. So strongly recommended. Well, folks, I think we're going to have to wrap it up there for today. It's Fertility with Fink and Friends on Tuesday afternoon. We'll be here every Tuesday at 4 o'clock Mountain Time, and I hope you will be too. So nice to see everybody. It's really a privilege to be able to spend some time with you here to talk about things that are important to all of us. And just know our thoughts and prayers are with each of you as your journey moves forward. And thanks so much again for being with us. God bless you all, and have a good night.